morning, our speaker is Dr. Annabel K. Wang. She is from the Department of Neurology and the director of the Neuromuscular Diagnostic Laboratory. And she has graciously given up her Sunday morning to come and share her thoughts and her knowledge about peripheral neuropathy. So please welcome Dr. Wang.
Thank you. Well, good morning, and thank you for all being here so early. I've just looking through your program, and it looks like you have some of the top speakers in the field, so I really am going to concentrate on peripheral neuropathy rather than talk about vasculitis and the treatment of it, although I'll have a couple of slides with that. So when we talk about peripheral neuropathy, that just means a problem with the nerves. Generally, when people refer to the term peripheral neuropathy, they mean polyneuropathy, so that means several nerves affecting the hands or the feet. Now, polyneuropathy that's not related to injury is actually a very common problem because about 8 in 100,000 people have polyneuropathy. Fortunately, a very small subset of the polyneuropathies are caused by vasculitis. We don't actually know how many people with polyneuropathy have vasculitis, but to give you an example, if rheumatoid arthritis occurs in about 1% of the population, and 15% of those people have vasculitis, only half of those will have a neuropathy related to vasculitis. So that's 0.1 per 100,000. So really a small proportion, but an important proportion. And vasculitis is something we always think about when someone comes to our office with polyneuropathy. Now, I'm sure that this has been explained to you before, and most of you know this, but the neuropathy in vasculitis is different from some of the other causes in the sense that it really is a mini stroke of the nerve. So the vasculitis will either cause a thickening of the blood vessel, which decreases the blood flow, or the blood flow is completely blocked, or an aneurysm or balloon is formed and the blood doesn't get through. I can see that these topics have already been discussed, the primary, secondary vasculitis, vasculitides, and the secondary vasculitis are things like hepatitis C or medication-related vasculitic neuropathies. But there's an entity called non-systemic vasculitis, and those are the cases that really the neurologist would see. And those are people who have problems of their peripheral nerves due to vasculitis, but no other organ system is involved. So it's a very limited form of vasculitis. Now, vasculitis tends to occur in people over the age of 60. Like most autoimmune disorders, tends to affect females more than males. It's treatable, but as many of you know, you can be left with a significant amount of pain or weakness. Now, neuropathy precedes the diagnosis of vasculitis in about 70% of the cases, so it really is up to the neurologist to understand that the vasculitis is in there and then get the other specialists involved to prevent damage to the other organs. And as you know, if it's not recognized, it's potentially life-threatening, and not so much from the damage to the nerves, but from damage to the other organ systems. Now, the patterns of vasculitic neuropathy are typically one of where individual nerves are affected. So you may have numbness in one part of your arm or one part of your leg, followed by weakness, and it's a very patchy onset. That's easy to recognize if you're thinking about vasculitis, but the majority of patients who have vasculitis present with tingling in their toes, which moves up their legs into your hands, and that's very non-specific for any form of neuropathy. And then you have perhaps the individual nerves being affected, but it happens so quickly that it really looks like your typical distal symmetric polyneuropathy. So again, the vasculitis may not be recognized because it's not what we call the characteristic pattern. Now, often people wasn't sure if it was something I said. So you may have proximal deep aching pain, just this ache that you really can't describe, that's in your arm or it's in your leg. Then you have burning, often in the distribution of an individual nerve, and then the weakness comes on. It can affect any type of nerve, so it can be just sensory, feeling nerves, it can be just weakness, motor nerves, or nerves of what we call the autonomic nervous system, so the nerves that control our automatic functions. And the things that we look at as peripheral neurologists are things that control sweating, blood pressure, and heart rate. But certainly autonomic nerves affect the heart, the lungs, the GI tract. So basically any nerve in the body can be affected. Typically the symptoms begin in the legs before the arms, but if it starts in the arms, it doesn't mean it isn't vasculitis. And it doesn't always occur as quickly as you think it might. So this can go on for weeks, months, even years. So the aching may go on for years before the weakness actually begins. Now this is just to give you an idea of the distribution. These are the typical patterns, but again, if you don't have the typical pattern, it doesn't mean you don't have a vasculitic neuropathy. Usually we'll hear stories about aching and then the foot slapping. So people tripping over that foot before anything else, but they can have weakness standing on their toes, spreading their fingers apart, holding things with their hands. It's really that asymmetry, so the individual nerve that's affected, that helps us to recognize the disease earlier. The difference with vasculitic neuropathy is they're often systemic symptoms. So that gives us additional clues that there's something else we should be looking for. So most people with a polyneuropathy would not have fever, weight loss, fatigue, rash, arthritis, symptoms that are suggestive of the brain or the spinal cord, so the central nervous system, and then other organ involvement. So those are signs that help us recognize that there's something more serious going on and we have to act quickly on this. Now this is just a picture of a nerve, just to give you an idea, see the arrow here, that there are blood vessels that run on the outside of the nerve and on the inside of the nerve. And the pathology or the mechanism behind vasculitis is what we call axonal. So it affects all these wires or cables running through the nerve. You may have heard of the term demyelinating when people talk about neuropathy. And that talks about the myelin, which is, if you think about an electrical cord, it's the outside plastic sheath. And when the plastic sheath is damaged, it responds fairly well to treatment, and it can respond fairly quickly. But when you start damaging those electrical wires inside the nerve, it's much more serious, and it takes a lot longer for those nerves to recover. And this is just to say that, again, it's what we call an ischemic or an axonal injury. So it's a problem of the blood vessels supplying the nerves. And that's why I use the term a mini stroke of the nerves. Now, there are many other diseases which can look similar to vasculitis. And so we often do a workup to make sure that we have the correct diagnosis so that you are receiving the proper treatment. And I'm sure for those of you who have neuropathy, you've been through these tests, but I'll just outline these for people who perhaps haven't had them. So EMG is what we call the electrical test, and it's a combination of nerve conduction studies and a needle electromyography. So the nerve conduction studies are basically electrical shocks where we record from either the sensory or the motor nerves to see how those nerves and muscles are working. And then the needle electromyography is actually a small needle that's put into the muscle so that we can record directly from the muscle. And that gives us information about several things. One, it tells us what the duration of the disease is, gives us a sense of prognosis if things are recovering. It tells us whether or not this is a demyelinating or an axonal form of neuropathy. It will tell us whether or not perhaps there are other things involved, such as the muscle or the nerve roots. So perhaps the pinched nerve in the neck, which is unrelated to the vasculitis, may be playing a role. And it helps us, one, to make the diagnosis, but also to guide the therapy. And sometimes you feel that the tests are not being done as quickly as you would like. And there's a reason sometimes for delaying the tests. Because even though the nerve is injured, it takes time for the nerve to show the changes. So sometimes it's too early to do a test. And so we may decide to defer the test for a week or so to increase the yield of the test. At the same time, we may do the test in what we think is a timely fashion, but we don't see the changes that we expect. And so we'll ask you to come back for a test. And patients will always ask you, why do I need to come back for this test? Which can be very uncomfortable. But it really is a timing issue, and sometimes we can't be sure, especially if we're not sure when the onset of the symptoms were, because this aching pain is very nonspecific, and sometimes you can't just put a start date on it. Now, a lot of times you'll also feel that as a patient you go in and these doctors, they just order so many blood tests. Part of the problem is that you can't put all the blood in one tube and send it out. Every blood test have to have a different tube, and that tube has to be filled to a certain amount for the lab in order to process it. So it's not that we're trying to take all of your blood, but there is a reason for all those bottles that we take. And what we're looking for, of course, is evidence of inflammation. We are looking to see how your kidneys and liver are functioning, because those are two organs we can test, looking at your blood. And if we're not suspecting vasculitis and we see abnormalities, that changes how we might approach your condition. There are infections that can be related to vasculitis, particularly hepatitis C. Some cancers may present as an inflammatory disorder in the nerves. And then we'll look for simple things like a chest x-ray. So if we see some involvement in the lung, again, that will point us in the right direction. And then the urine analysis is yet another way to look at the kidneys. And then a lot of times we have to proceed to biopsy. And I'm sure that this has been discussed before, where it is important to be sure that you actually have a vasculitic disorder going on because of the treatment plan that will follow. And sometimes we are fooled. And having a tissue diagnosis really helps us to solidify the treatment plan. And I'll just actually show you pictures, which is a lot more helpful. There is an entity called fibrinoid necrosis, so that the blood vessel walls are breaking down. And I don't know how clear it is, but there's actually no hole in this blood vessel, so it's completely blocked. And all of this is inflammatory cells, which you wouldn't see in a normal nerve. And then here you can see that this pocket of nerves, which we call a fascicle, looks fairly good, but if you look at these two over here, there are no nerves or nerve fibers in there, and that's typical for vasculitis. So seeing a picture like this helps us solidify the diagnosis. And then over here, in a later stage, you can see that there are these little whorls in here, and that's recovering nerve, which is occurring outside of the nerve. And then again, sorry, that's a picture that's consistent with vasculitis. So these things help us make sure that we have the correct diagnosis. But this also tells us that this is a long and chronic process. There's no more inflammatory cells in here, so perhaps the treatment may not be helpful because the damage is already done. I won't go through the treatment because it looks like other people have explained it in better details. And typically, if I have a patient who has vasculitic neuropathy, I'm going to be working closely, usually with a rheumatologist. And I will guide the nerve aspect of it, but all of the other organ systems I'll leave to the rheumatologist. So we actually work as a team, and if we need to, we bring in the cardiologist and the nephrologist, whoever else is appropriate. And again, the rationale for doing such a big workup is these drugs are not benign, and for a condition like vasculitis that is potentially life-threatening, the side effects are worth the treatment. There are many neuropathies where it is not worth having any side effects because the neuropathy itself doesn't have any effect on any of the other organ systems and really is not life-threatening. So we have to choose our medications carefully. Cyclophosphamide, I know, has been brought up before. It's a really good drug. It works extremely well, but it does have its side effects and it needs to be monitored closely. And the other thing is that vasculitis may require long-term treatment, and there are risks of other infections and other complications that one has to be monitored for. So again, the emphasis is on the correct diagnosis. I won't talk about these other treatments, but there are other medications available if you have problems with steroids or cyclophosphamide. If there's an underlying infection, treating the underlying infection is just as important as treating the vasculitis, because if the infection is not treated, it will continue to cause problems. And actually, immunosuppression can make the infection worse. So it's a very difficult situation when you have a vasculitis related to a primary infection. This is probably difficult to see, but there are many medications available for pain management. The problem with a lot of medications we have is they are not FDA approved for neuropathic pain. Most of the medications that are approved are either for zoster or for diabetic neuropathy, but the mechanisms are similar, and so we have to use them what we call off-label. And we do need to explain to you that these are medications that are used for depression or for epilepsy, but they work very well for pain. The most important thing is to realize the side effect profile. So many of these drugs can affect the heart, so you do want to know that before you start. And because a lot of these medications are anti-seizure medications, you cannot stop them abruptly. So you may feel that the medications are not working or the side effects are really bothersome, but you still have to decrease it slowly, because if you stop it abruptly, there is a chance that you could precipitate a seizure, which just then complicates all of your care. And aside from medications, the other important things are physical and occupational therapy. The important thing to realize in vasculitic neuropathy is that therapy is not going to make the weakened muscle stronger. You have to let the nerve recover. But what you can do is strengthen the other muscles surrounding, increase just overall strength. And then the other things that are very important are orthotics and braces. And I know that a lot of patients don't like the braces because they are ugly, but they are getting better. But the important thing is to keep that limb safe. Most of the time it's a foot drop. So it's preventing injury to the ankle so that you don't sprain the ankle, you don't tear ligaments, you don't tear tendons, because we don't have good treatments to fix ligaments and tendons. Excuse me. And you're left with a lot of pain due to ligament and tendon injury, which we can't do anything about. So we may treat your vasculitic neuropathy, may improve everything else, but then you'll be stuck with these injuries, which will continue to bother you for the rest of your life because we really don't do a good job. The other thing is assistive devices. So the other thing that's very important is to prevent further injury. Now, many patients with vasculitis will be on steroids, which thin the bones. So if the only thing we can do is prevent you from falling and breaking a hip, or even worse, falling and hitting your head and perhaps causing some more severe damage, then we've done a great thing. Another thing that I talk about is conserving energy. So when you have some weakness, the day-to-day things take a lot of energy. So I suggest conserving your energy for, let's say, getting from the car to wherever it is you want to go. Or if you want to go out and go to the museum, take a chair and just sit and enjoy the museum rather than worry about the fatigue or the pain that comes from standing on your feet for several hours. So it's trying to look at these devices in a different way and use them to your advantage, and the hopes is that with treatment, these issues will become less of a problem and you won't necessarily have to continue using them. So just to pull this together, it is important for the neurologist to recognize vasculitis as a cause of neuropathy, because early diagnosis will prevent future problems and future weakness, morbidity, even possibly death. Because this is an axonal form of neuropathy, recovery is very slow. It's 1 to 3 millimeters a day. So whereas we may not be able to prevent the first injury to the nerve, we can prevent other nerves from being involved and really try to limit the morbidity. The neuropathy from vasculitis can recur, so it is not as if it's a one-time event. Like other symptoms of the vasculitis, you may need to be maintained on medication long-term, but we have to balance that with the toxicity of treatment. And these are just my references, so I'm going to stop here and take any questions. Okay. Now, were we going with questions or written questions? I'm not sure.
Usually somebody's been monitoring the written questions.
Okay, when we start, and we'll move our way back.
Yes. If you've had neuropathy in, say, a thigh muscle for 10 to 15 years before vasculitis, do you think treatment is not warranted at all because it's probably not going to cure it?
So the question is, if you had vasculitis in a thigh muscle for very years, Do I think that?
No, I had the neuropathy before the vasculitis.
Okay.
So I don't think it's associated, but the treatment will be warranted or not. That long period.
It really depends on the evaluation. So what we see in the workup, because if, for example, we did the electrodiagnostic study, so the EMG, and we saw that there was still damage ongoing, or if we took a biopsy and we saw that there were still inflammatory nerves within the muscle or the nerve, then it would be worthwhile to treat. But if we did all of that and it looked chronic and it didn't look like anything new was happening, and that recovery, even though incomplete, had occurred, then we certainly wouldn't expose you to any medications. The one with the glasses? Sorry, you're both wearing glasses.
For years, I've been trying, I had cryo for like 8 years, and I've been in remission, and when I came out, I thought I could do it soon, and started writing my legs. They, just like that thing said, no doctor's ever been able to, they just look at me like I'm crazy, but my thighs up here, they just sting. They just sting so bad, and they throb, and I'm trying to tell my doctor, since it feels like I have polio, although I've never had it, I don't know what it feels like that. And they just look at me, and then they just say, well, walk. But see, that's not what I wanted. And it hurts. It's just like on that thing with that bead.
It's hard to tell from here, but certainly, but it's worth investigating. Right.
Close to what I feel.
Right. So it would be worth seeing someone who is, an interest in neuropathies or has experience in vasculitis, regardless of what type of doctor it is, and then reevaluating. Because there's two separate issues. There are your symptoms, and then there's the cryo. So obviously, one would want to make sure that the cryo was treated, and then evaluate, what happens to your symptoms. So you need to step back a little bit and see what's actually going on right now.
But there's a possibility for help.
Yes. Okay. Next question.
I want to say for me, myself, I've had neuropathy for a while. Gabapentin didn't work. I was lethargic, sleeping all the time, putting on weight, losing my hair, all the above. They changed me over to Lyrico, which made me psychotic. So I had to come off all these meds. I was still treating with the cyclophosphamide and high doses of prednisone, and I wasn't getting any better. One morning, out of frustration, I went to the computer and I punched in nerves and oil, and it came up with it came up with eucalyptus oil. So I read it, I printed it all out, I brought it to my doctor. Meanwhile, I had my daughter go to a herbarium in the area, and the man there, who has been in practice for over 20 years, said yes. And she showed her how to make a concoction of the oil and lotion, and I started to apply it, and my symptoms went away. It didn't cure the neuropathy, but the burning, the stabbing, the stinging, the pain, excruciating, can't put my feet on the floor, kind of thing. My doctor told me that it was okay for me to use it because it didn't have any adverse effects with any of my other medication. So I've continued to use it. I know someone else has used it, and they like it also. So why wouldn't something like that be prescribed as topical medicine in conjunction with maybe some of these other Eastern and Western?
Right. So the question is, why isn't something like eucalyptus being prescribed? And there's two issues. One, as I described with some of the pain medications, is they're not FDA approved. So there haven't been clinical trials. So while it may work for some people, it doesn't work for a lot, for other people. The other thing is the way it may be processed. Because it's not FDA approved, no one is actually monitoring how it's being processed. And so there have been incidences in the past where things that are not FDA approved are actually contaminated. And so people actually got sick from taking something that potentially could have been helpful. And unfortunately, there are a lot of people out there who are also looking to make money, and there is no active ingredient in a lot of these things that you buy. So it is difficult. We do encourage people to look at different websites, and one website that talks about perhaps over-the-counter treatments is the Neuropathy Association. They have a website and they have chats. You just have to remember that not all neuropathies are the same, and what people discuss are not FDA approved, so we can't guarantee you any safety. We can't guarantee that something won't go wrong. That's the biggest problem. Okay. Back here. Okay, and then I'll get to all these questions.
I've never been to a neurologist, but I had cancer 10 years ago, and about a year after my chemotherapy treatment, and I asked my surgeon, he said, oh, that is because of chemo. Oftentimes chemo will cause neuropathy. It's just a very numbness in the ball of my feet. And then a year and a half ago, I was diagnosed with MDA, and I was put on high doses of prednisone, and it seems to get worse, where I actually have pain in my toes. I no longer have prednisone, but at night, my feet hurt. I mean, my toes hurt, and I take 300 milligrams of gabapentin before I go to sleep, and then I feel much better when I wake up in the morning. But I was just wondering if that's true, that chemotherapy can cause neuropathy, and that my neuropathy was not related at all to vasculitis, because I didn't know I had vasculitis until a year and a half ago.
Okay, so the question is whether or not neuropathy can be caused by chemotherapy, and yes, it is a very common problem. Whether or not your neuropathy is related to the vasculitis, of course, is difficult to tell. There's no reason why you couldn't have two problems going on. So it's worth going back to whoever's taking care of your vasculitis and discussing that. Okay.
What did you say? She took 300 milligrams of what?
Gabapentin or Neurontin. Okay. So, let's see if I can go back. So gabapentin is an anti-seizure medication, Neurontin. It has been used in zoster, postherpetic neuralgia, and it has been used in diabetic neuropathy. It just treats symptoms. Okay, one more question, and I'll get to these. Okay.
Is there a method to diagnose the difference between diabetic neuropathy, vasculitic neuropathy, neuropathy caused by meds like chemotherapy, or even medicines that we take, prednisone, Imuran, as
There is. Certainly with diabetes, it's a question of blood sugar control. So if you have diabetes, you will have some component of neuropathy. It's very unusual for someone with diabetes not to have any neuropathy. But if your blood sugars are high, or if your blood sugar control is variable, meaning that it's very high and very low, the likelihood is you're going to have some component of diabetic neuropathy. Vasculitis, you should have the markers that I talked about in the blood. So something in your blood, perhaps on your nerve biopsy, that would explain it, or something systemic, so that you have proven vasculitis, but it's easier if we can actually show it in the nerves to be certain that it's related to the vasculitis. And then for chemotherapy, it depends on the medication, and it depends on the timing of the development of the neuropathy. So if you had chemotherapy and then 10 years later you developed neuropathy, it's very unlikely that the two are related. And then medications, again, it's a temporal thing. So typically antibiotics will cause symptoms of neuropathy. So if you start a new antibiotic and you develop new symptoms shortly after, the likelihood is they're related.
Have you ever heard of Ambien causing neuropathy?
No. No. Nothing's impossible, but that's nothing I've seen before. Okay?
And diabetic neuropathy would go away then when sugars are controlled?
No. The damage is usually done most of the times because the diabetes is unrecognized for a while before the diagnosis and treatment is started. If we catch someone fairly early on, we may be able to reverse some of the symptoms, but typically the neuropathy does not go away. The goal in diabetic neuropathy is to prevent further worsening. Okay, so the vasculitis, it's a little bit different because if you can get the vasculitis under control, meaning you remove all the inflammation, there's a chance that things will continue to improve. The difficulty in some of the vasculitides, and I can't speak for all of them, is that if you can't get the inflammation under control, then you don't know if the symptoms of the neuropathy can improve because there's still ongoing inflammation. So the cause of the neuropathy is still there. And that's the problem with the diabetes, is that no one's ever really cured from their diabetes. We can improve them and get them under control, but they still have diabetes. Okay, so let me just go through some of these questions here.
Can I ask a question in reference to that? What is the difference between their neuropathy and neuropathy caused by vasculitis? Because they lose digits, or they can lose a foot, etc. on the leg.
The difference in diabetes is it's not only the neuropathy that's playing a problem. They actually have problems with their blood vessels that's ongoing, so that if the diabetes is not treated, the blood vessels don't work the way they're supposed to, whereas in vasculitis, where it is an inflammation of the blood vessels, it's not all the blood vessels. And the treatment of the vasculitis treats those blood vessels, whereas treatment of the diabetes doesn't necessarily treat the other complications of the blood vessels. Diabetes is a lot more complicated in that sense. Okay, so I have continuous burning under the facial skin without readiness. Would this become a weakness in the facial muscles? In my youth, I had Bell's palsy for 3 months. So it's difficult to answer this question. If you had Bell's palsy, usually it's a one-time event, so that's a facial nerve weakness. It tends not to recur unless there was an underlying disease that caused the facial weakness. So for example, if vasculitis does not typically cause a facial palsy, but other diseases can, and so if that disease is not treated, it may come back. But the continuous burning under the skin, it really depends on what else is going on, so I can't answer that question specifically. The next question is, does the use of prednisone skew the results of EMG nerve conduction studies and how about a biopsy result? So prednisone typically does not skew the testing results. It can affect biopsy results in the sense that if the prednisone is working and it removes the inflammation and we take the biopsy after someone has been on prednisone for a long time, we may miss the inflammation. But the other chronic changes that I showed you may appear, and that still may help us. But ideally, for vasculitic neuropathy, we like to biopsy before treatment is started or as soon as possible after treatment is started. If you're being diagnosed by the neurologist will do the biopsy first because that's how we will make the diagnosis, and then the prednisone will be started. So this probably would occur in a different circumstance. The next question is it typical for neuropathy to come and go, specifically within days? It depends on what the symptoms are. Typically, sensory symptoms do come and go, but if it's related to vasculitis, it tends not to be because the inflammation's ongoing. But what I do tell people, if things come and go, that's something you need to monitor, not necessarily worry about. But certainly if things change and become constant, then that is something that should be investigated. And then the other question is, does it usually begin with a rash? And not always. If there is a rash, it makes it a little bit easier to make the diagnosis of vasculitis. And then the next question is the relationship of increased eosinophils to relapse in peripheral neuropathy. I assume this is related to Churg-Strauss, and if that were the case, then yes, there probably is a relationship. But as in all things in medicine, we don't just take one blood test to change medications, particularly medications with side effects. We want to take a look at the whole picture to make sure everything else is truly worsening and that there isn't another cause for the change in the eosinophils. And eosinophils can occur if you're having an allergic reaction to something. So that would be something important to rule out before you change the treatment of the peripheral neuropathy. The next question is, does a foot drop go away? A foot drop can go away. It depends on how severe the damage was. And so that's where all of the other testing will allow us to give you a prognosis. Depending on how much damage was gone, where the damage was caused from. You can have a foot drop from peripheral neuropathy, but you can also have a foot drop from, let's say, problems in the back. And so if you were an unfortunate person that had several causes of foot drop, it might not go away. So it really is situation specific. Can vasculitic neuropathy affect balance? Yes, it can. Any neuropathy affects the sensory nerves, and what happens is a person with neuropathy doesn't know where their feet are. So you may step on something and your reaction would be to right yourself, but if that information doesn't get to your brain fast enough, you'll fall down first and then realize that your balance is off. So people who have balance difficulties shouldn't walk in the dark by themselves. They shouldn't do anything besides walk, meaning that if you're an uneven surface, you should be walking with someone else. I tell people that if they want to window shop, they need to stop and look and then keep walking, because you really do have to pay attention, because your feet are not going to tell you that there's a problem with your walking. You really have to use your eyes. And so it is actually very important that you maintain the health of your eyes as well. When I am taking prednisone, I sometimes develop cramping in my legs. Is that caused by the nerve damage? Cramping is a very non-specific symptom, so it can be caused by anything wrong in the neuromuscular system. So if you have a problem with your back, if you have a problem with your muscles, a problem with your nerves, you can have cramping. It's not necessarily related to the prednisone, just to the nerve damage itself. Cramping is very difficult to treat, as probably a lot of you know. The Neurontin or the gabapentin, which we use for the sensory symptoms, can sometimes help. Sometimes warm baths can help, sometimes stretching at night. Other people have tried tonic water. Tonic water has some quinine in it. Usually would tell people to take the sugar-free. As some of you may know, quinine tablets, which we have used in the past for cramping, is no longer available on the market. There are homeopathic pills available, but as I said before, those are not FDA approved, so we don't actually know what's in those tablets. It says normal EKG test, but stated sensory neuropathy due to vasculitis. Will that type of neuropathy improve with time? I think that's really, I assume that means an EMG, so that's the nerve conduction studies. A lot of times it just depends, again, on the timing. So it depends on when the study was done. Sometimes the changes can be mild and not picked up on our tests. But if you are being followed, the changes will probably occur, and this is a situation where a follow-up test is probably warranted. The next question is, can peripheral neuropathy cause so much pain that patient is on 3 different types of pain medications, such as Dilaudid, OxyContin, and fentanyl patch? Can you have peripheral neuropathy in the stomach area? So yes, the pain can be very severe, but it's worth stepping back to see what the actual pains are, because not all of the pains may be peripheral neuropathy related. If you need to be on that many medications, I always work closely with my pain management doctors, because they are much better at dealing with severe pain than I am. And again, it's part of the team concept where I can take care of some of the issues, but I'm not the expert in all of them. And so having a good partner in this area is very helpful. One thing that's important is setting the proper goal. So whereas the pain can be severe, what I tell my patients is that if your pain is a 10 on 10, we should be looking to decrease your pain to 4 over 10. Okay, you're not going to be pain-free in most cases without significant side effects. So we certainly can get rid of the pain in many cases, but you probably can't function. So I'm not sure that we've done you any service. Once you get to 4 over 10, then you can readdress the medications and see if you can improve on that. But I think the initial goal is not to be pain-free, because that really is not a realistic goal. And the other question is, can you have peripheral neuropathy in the stomach area? Yes, you can, because there are sensory nerves across the stomach area, although typically people will describe more of a shield So it's really the entire front of their body that has a decreased sensation. Does a diagnosis of small fiber neuropathy refer to the area on the outer part of the nerve? This has not been presented on my EMG tests. I have Wegener's in several veins in my hands, feel like I am always having an IV started. Is this part of the small fiber neuropathy? I take Lyrica, which does help with the symptoms. And so this brings up an important point that I didn't discuss, and there are what we call large fiber neuropathies, or the large fibers, and they control our ability to sense vibration and position. And that's really the balance issue. Now, the smaller nerves are those nerves that control temperature, pain, and actually these are the autonomic nerves that I referred to. So having a small fiber neuropathy just means that the nerves that are being affected can't be seen on conventional nerve conduction studies. Now, we do additional testing on what we call the autonomic nerves. So we test those nerves indirectly by looking at how a person sweats, because the smaller nerve fibers are involved with the sweat glands. And we also look at blood pressure and heart rate control to different maneuvers, because those are also the small nerves. And we can make a diagnosis of small fiber neuropathy. Other centers can diagnose small fiber neuropathy using skin biopsy. It's not something that we do routinely, but certainly can be done. And there are some commercial labs where you could do the biopsy and send the results to. The sensation of having an IV started could be related to the small fiber neuropathy. And Lyrica is a good medication for sensory symptoms. Lyrica, I should say, is approved for diabetic neuropathy, but we do use it, of course, for other neuropathies.
How's that spelled?
Lyrica, Lyrica. The generic name is pregabalin. Are palsies under the umbrella of neuropathy, e.g. sixth nerve palsy? Yes. As I said before, neuropathies just mean a problem with the nerve, so basically it's any nerve in the body. We tend to lump sixth nerve palsies more with the cranial neuropathies, but that's just labeling, really. It's just another type of nerve damage. Is it advisable to have a neurologist on the medical team in addition to rheumatologists when peripheral neuropathy is present? I can't answer that in an unbiased way, of course. I think so. But it really does depend on your rheumatologist. It depends on your specialist. There's some people who are very good, and if you think about it, that is one more person to see, but if you feel that your needs are not being addressed, in most major centers, the neurologist and the rheumatologist do work together. Is the variation of pain, e.g. burning temperature, pinpricks, to knife stabbing and just numbness, an indication of CSS flaring or permanent nerve damage? The problem with neuropathy and pain is that pain can occur in multiple situations. So it can occur because of the underlying disease, so the Churg-Strauss, or it can occur because something is getting worse. It can occur because the nerves are trying to recover. And if you think about electrical wires that are sort of snapping and flaring and making all these noise, the nerves are telling you that they still work, and so they give you pain, which in many ways is a backwards good sign. So if your pain starts to get worse, it may actually be a sign that your nerves are getting better. And then any illness or stress can make your sensory symptoms worse. So if you have a fever, the likelihood that your pain will get worse. So we do have to be careful about looking at the particular situation and where things are getting worse. The next question is acupuncture and peripheral neuropathy. There have not been good clinical trials, but in the right hands, acupuncture is a relatively benign procedure, meaning that it's very unlikely that they're going to do harm. The most important thing is that you be treated by someone who is trained in acupuncture and then uses disposable needles. But I think that if it can relieve your symptoms, and it's usually the sensory symptoms or the pain that we're looking at, if it can help and if it can get you off of some of the medications that are giving you severe side effects, I think it's worth discussing. At my institution, we have a center for alternative medicine. So we are working with people who are interested, well-trained, but also interested in the research and the academics behind it, so that hopefully by referring patients to these particular caregivers, we're going to learn more about the role of acupuncture in peripheral neuropathy and try to prove that it actually is a helpful treatment. And the last question here is, what role does neuropathy play in the loss of motor control, loss of ability to hold utensils, and how can this be treated? Neuropathy can certainly play a role in the loss of motor control, but it can be caused by either weakness or lack of sensation. So part of that is not knowing as you walk where your feet are, not knowing where your hands are, and so not being able to coordinate the movement. The treatment does depend on the type of neuropathy, so if it is, let's say, a vasculitis and it's treatable, that may improve. But this is where working with your therapist is very important, your occupational therapist, and those are people who work with hands, who help you, in particular using weighted instruments or perhaps braces on the hands, and help you improve the control of your hands. Okay?
Any additional questions?
Yeah, I'm just going to throw one out there. I always want to have a question about, can peripheral neuropathy come and go? Because I've heard this from a few people with vasculitis, like they'll feel numbness in their leg for 2 or 3 days. It might be in their chest and it seems to spread and then it goes back down. Does that mean that if you have vasculitis and it's happening, that you're actually, something in there is inflamed? Or is that just possibly a side effect of the drugs, and how would you tell?
If it was the vasculitis getting worse, hopefully you'd have some blood markers that would change, that would confirm it. The drugs, it really depends. Most of the drugs that are used for treatment shouldn't cause a problem except for steroids. So if you were developing diabetes, that would create a second problem. But it really is situational. It is evaluating all of those things for the individual before jumping at the conclusion that the disease is getting worse. Okay. Yes?
I am very sensitive to drugs. Is this connected in any way?
Did it come on after developing?
Pretty much.
Okay. It's possible. I mean, certainly the hearing nerves are nerves, and certainly can make a change. It's not something that I've typically heard, but it's not out of the realm of possibilities. And there are ways to test the hearing nerves. So,
I had a hearing test, but that turned out to be fine. My hearing is fine.
yeah, there are some probably more sophisticated testing. There are very few people who are interested in that field, but there probably are ways to look at it.
Okay, I just put it
That too. That's probably the simplest thing to do.
You mentioned about sweating.
Yes.
in neuropathy. Does it also prevent sweating? Sometimes I sweat profusely. I mean, like I just stepped out of the shower. And other times I don't have any, I'll go days before, like, wow, did I even sweat today? You know? And I work out all the time. So
Right.
it's reactive.
The sweating tends to be consistent, so that if you don't sweat, you'll never sweat. But one thing to pay attention to is where you're sweating. So if your hands and feet don't sweat, the remaining parts of your body have to compensate. And this is really about temperature control. So that if you were getting overheated, the remaining parts of your body will sweat even more to try to regulate your temperature. And that, you bring up an important point. If you don't sweat, you are more likely to faint or to develop heat intolerance. So it's very important to drink a lot of fluids and to stay out of the conditions that will precipitate the symptoms. Okay, person in back.
With leg and foot cramps waking you up in the middle of the night with excruciating pain, the only way I get some relief is to get out on a cold floor. Is there anything we can do about that?
There are no great treatments. It's a little bit of trial and error. So it is trying to keep your limbs warm. Some of the treatments for pain may be helpful. Stretching, and I mentioned the tonic water that helps for some people. But
the tonic water,
right.
I do stretching because I'm a professional walker.
Right. No, we do a terrible job with cramping, and a lot of times you figure it out on your own because everybody's a little bit different. But no, unfortunately, that's something we all struggle with.
Is it normal to have foot problems when you go to bed to get the pain to stop within, taking about a half hour or an hour to get to sleep because my feet are hurting? Is that normal?
It's normal for, I wouldn't say it's normal, it's not uncommon for people's symptoms to be worse at night, and that's in part because most people are busy and they're able to block out a lot of the symptoms. And the fact that, you know, if you're busy all day, you're probably tired. That's not unusual, but yes, it does take time for things perhaps to calm down before you fall asleep. And that's why a lot of people take their medications at night, because if they can get a good night's sleep, a lot of their symptoms feel better. And that again is another important point, but particularly if you're taking steroids, is sleep is crucial. So if you don't sleep well, your pain will be worse, and it doesn't necessarily improve with more pain medications. It's sort of making the other lifestyle changes. The other thing that can cause foot pain is arthritis, and that's one thing we do have to pay attention to, as well as plantar fasciitis. So that's the stretching of the fascia in the bottom of the feet. And so if you, it would be different from what you're describing. So if you get up in the morning and you stand up and you have the most excruciating feet as you put your feet on, pain in your feet as you put your feet on the floor, that's something different that can be addressed by a podiatrist and wearing good orthotics. Okay.
I've never experienced the like the muscle weakness that you're talking about with the neuropathy. I went through some periods where I had kind of a tingling or sensations in the arms and the fingers, and now mostly it's just in the feet. And I'm just wondering if it really is neuropathy. I don't know if I've ever actually had it diagnosed as neuropathy. I just assumed that it was because of the kind of the stuff that I had heard about it. But in my feet, even like right now, just sitting here, kind of in the balls of my feet, I feel kind of tingling, or kind of like they're, you know, like if your foot falls asleep. But I can still move it just fine. I just have kind of that kind of tingly feeling. Is that what you would consider neuropathy?
It can be, because neuropathy can only affect the sensory nerves and not the motor nerves, so you don't have to have weakness to have neuropathy, but we do like to prove it using electrical tests, because tingling is a very non-specific symptom, can be caused by different things as well.
I wrote that test down to see if my doctor might be interested in trying that one out.
Okay, great. Over here?
Can neuropathy also occur in the head?
It can, yeah. There are facial nerves as well, so they're nerves that control the sensation in the face.
What does that look like?
It's just a feeling. So,
Just again, it's just a, okay.
yeah, if that's just a sensory nerve, and then if there's weakness, then you wouldn't be able to move the face. Okay, over here.
I have, my neuropathy is different in that I have diabetes from steroids. It comes at night, starting anywhere from 5 or 6 in the evening, and progresses to awful by 9 o'clock at night, and gets worse. When I wake up in the morning, it's gone, and that's like death and taxes. What's up with that? And I don't know whether it's Wegener's, I don't know if it's diabetes.
I'd have to ask a lot more questions to get to that. Okay. Yeah.
What about the IVIG? A doctor told me that would be really good for the neuropathy, but I've never really heard of it.
IVIG is intravenous immunoglobulins, and it is a treatment for immune disorders. It really depends on what symptoms are being treated. We try to keep IVIG in reserve mainly because it's very expensive. It can be as much as $10,000 a treatment, and coverage is variable. So you do want to use it mostly for weakness. I don't tend to use it for sensory symptoms. But of course, if there are other organs involved, that's a different issue. It is a pooled blood product. So in theory, it has the same risks as receiving a blood transfusion. Even though we don't see it anymore, we know that hepatitis and HIV potentially could be transmitted, or if the patient has any other diseases, potentially those could be transmitted. Those are the worst things we worry about, but there are headaches, rashes, and in the odd case, in someone who is already risk at stroke, it may precipitate a stroke or another blood clotting event. So it's not a completely benign treatment. Those side effects are fairly rare, but it doesn't matter if you're the person getting them. Even if it's 1 in a million and you're that one person, it can be pretty significant. Yes. Yeah.
Oh, yeah, hi. I just want to share, do you remember leggings? The kids wore leggings on their legs. They were footless and they stopped at the knee like a knee sock. I'll tell you, that has been really warm. Yeah, leg warmers, right. Well, I use those. Then out of blue, someone contacted me through the VF and gave me a pair of Vaso wraps. They're Velcro, and I'll tell you, that has been a lifesaver for me. I put them on at night, I go to bed, I wake up, my legs are nice and warm, my feet are toasty, and it's really been a great help. So if anybody wants to know anything more about the Vaso wraps, I have a little leaflet. They're pretty neat.
We probably have time for just one last question.
Okay.
Is there a relationship between, itching of the arms or legs and peripheral neuropathy? Because I used to like to wear nylons or those, what she's talking about. And now I find that it just makes me itch intensely. So does it have any relationship with peripheral neuropathy?
It can. Sometimes, particularly the small nerve fibers, present as itching. People don't. The smaller nerve fibers that we were talking about that control pain temperature and the autonomic symptoms. In some cases, people present with itching before anything else, but you want to be sure that there's not a separate skin issue that's involved.
And could that be like, an indicator that you might be getting a more severe?
Not necessarily. That's where all the other things are important. Yeah, you never base anything on one symptom alone. Okay.
I'd like to thank Dr. Wang for being with us today.
Thank you.